The plasma cell dyscrasias are diseases of the bone marrow in which there is going to be monoclonal expansion of plasma cells. What the plasma cells end up doing is going to determine which disease it is. I know that sounds vague, but you'll understand by the end. We're going to start with multiple myeloma, the one you need to know the most about. And then we'll use that as a mold to talk about monoclonal gammopathy of undetermined significance and Waldenstrom's. Very wordy, but actually it's quite easy. So let's start off with multiple myeloma. Multiple myeloma is a disorder of plasma cells. And these plasma cells are monoclonal because they are cancer, and so there's a lot of them. And they do what plasma cells do. And in multiple myeloma, what they happen to do is make IgG. But they don't make real IgG. They make incomplete immunoglobulins. Plasma cells are supposed to make IgG in order to identify an antigen and tell the body to go kill it. Well, these cancer cells are kooky and they're saying, hey, go kill that antigen. And the body says, what antigen? Go kill that antigen. So there's lots of this protein being made. This incomplete immunoglobulin doesn't do anything against a phantom antigen, causes there to be an elevation in the protein. So you might see a protein gap. But the problem is that these plasma cells begin to crowd out the marrow, so good plasma cells can't do what they do, and they use up all the protein. So good plasma cells, which are trying to identify real antigens, aren't able, which causes patients to succumb to recurrent infections. But because of all this excess protein laying around, you'll see a protein gap on the LFTs, and you can get as an SPEP, a serum electrophoresis. What you're looking for is the M spike, the monoclonal expansion. A lot of this particular one protein that may be on the test labeled as electrophoresis or immunofixation. So you're able to identify this protein and start thinking about the diagnosis. They also make Bence-Jones proteins. And Bence-Jones proteins really are these incomplete immunoglobulins that deposit in the kidneys, and these cause kidney injury. And just like we can find the protein in the blood, we can also find that protein in the urine by getting a urine electrophoresis, where we'll see an M spike. And unique to this disease, what it happens to do is produce osteoclast stimulating factor. And osteoclasts clear bone. This causes the lytic lesions that lead to pathological fractures. That is, atraumatic fractures. And this may occur anywhere. Any bone may succumb to it. We can identify these lytic lesions by getting a skeletal survey. Now, it's important to notice that it's skeletal survey, not a bone scan. Usually when you think of metastatic cancer going to the bone, you want a bone scan which picks up osteoblastic activity. That would be indicative of a metastatic lesion. Multiple myeloma does not do that. They create mostly lytic lesions of osteoclasts, so you need to see the holes that they make. You see the lytic lesions or osteopenia rather than detecting metabolic activity. So get a series of x-rays to find the holes. Don't do the nuclear medicine scan. So to review, SPEP, immunofixation of the blood and the urine, will show a M spike, a single protein that's present. And multiple pictures with x-ray, the skeletal survey, will show lytic lesions. And that's how we link the pathology to the symptoms and to the diagnostic steps. Let's review it again. The patient presentation is generally going to be someone who's older, in their 70s, and they present with CRABs. Hypercalcemia, renal failure, anemia, and bone pain. Now, not every patient has to have all four, but if you start to see those things, think multiple myeloma. You're going to begin the diagnosis by getting an SPEP, which will show an M spike. And for the test, if they want you to know that it's multiple myeloma, the SPEP will be positive, the UPEP will be positive, and the skeletal survey will be positive. I want you to know that there's multiple variants from asymptomatic through smoldering to really bad myeloma, where there's different varying possibilities of the SPEP, UPEP, and skeletal survey. But for you, they're not going to be confusing. No curveballs on step 2. So the SPEP, UPEP, and skeletal survey will be positive. You get a bone marrow biopsy to confirm the diagnosis, which will show greater than 10% plasma cells. If the SPEP is negative or the bone marrow biopsy shows less than 10% plasma cells, that's not multiple myeloma. And again, they're not going to try to trick you up. Because these patients are generally old, your treatment is usually conservative. If they're over 70 or there's no donor, you are going to use chemotherapy. If they're less than 70 and there is a donor, you can do a stem cell transplant. I don't think you'll be asked to recognize the names, but I'm going to tell you them anyway just in case you need to. Chemotherapy usually is a combination of melphalan with steroids, prednisone, and either thalidomide or bortezomib. And these names are really hard to pronounce, and just so long as you can recognize them. But really what you want to see is older people, no donor, get chemo. Younger people with donors get stem cell transplants. Okay, hopefully that was very clear. Multiple myeloma, if you understand it very well, the next 2 diseases become very easy. Multiple myeloma, plasma cell dyscrasia, IgG, ends up with Krabs, and all the tests are positive. But there's a disease called the monoclonal gammopathy of undetermined significance. It is essentially early myeloma, but we're not sure if that's true. It might be its own disease. And it occurs in really old people, like greater than 85, and they will not have any symptoms at all. The diagnosis is going to start with an SPEP, and the SPEP is going to be positive. And you say, aha, SPEP positive, protein gap. This must be multiple myeloma. Remember, there are no symptoms. You do the rest of the workup, the UPEP and the skeletal survey. UPEP is negative, the skeletal survey is negative, and you're saying, well, hey, I thought this was multiple myeloma, let's do a bone marrow biopsy. There's less than 10% plasma cells. And because these patients are old, and there's no symptoms, and it's not myeloma yet, chances are they're going to die before anything bad happens. But you still monitor for the conversion to multiple myeloma, which happens at about a rate of 2% per year. All you need to do is observe, follow these patients up, skeletal surveys, waiting for it to transform into myeloma. When it does, you treat it just like myeloma. The other plasma cell dyscrasia is Waldenstrom's. Same pathology, very different presentation. This is a plasma cell dyscrasia, plasma cell cancer of the marrow, and it is secreting IgM. And because IgM forms a pentamer where IgG does not, the symptoms are very different. The patient is going to present either with hyperviscosity syndrome or constitutional symptoms. Night sweats, fevers, weight loss. The diagnosis is similar, right? So you're going to get an SPEP, and there's still a monoclonal expansion of that IgM, so it's positive. The UPEP and the skeletal survey are usually negative. So now you're starting to think it looks like MGUS, but they have symptoms. The bone marrow biopsy is going to show greater than 10% lymphoma. It's a lymphoplasmacytic lymphoma, but what you're looking for is basically lymphoma. And the treatment is going to mirror lymphoma more than it is the plasma cell dyscrasia. You're going to use a rituximab-based chemotherapy. And if they have hyperviscosity, you use plasmapheresis. All right, so let's point out the differences. In Waldenstrom's, The presentation is very different with hyperviscosity syndrome because of the IgM pentamer, and you're going to see lymphoplasmacytic lymphoma on the bone marrow biopsy treated with rituximab versus multiple myeloma where it was IgG and it presents with crabs, positive all the tests, and plasma cells on the biopsy. Multiple myeloma can be treated with stem cell transplant or a melphalan and steroid-based chemotherapy regimen. Whereas monoclonal gammopathy of undetermined significance looks like it should be myeloma, it's just not myeloma yet. So you're going to have to do two things. You are going to either see the person who has full-on signs and symptoms of multiple myeloma. They've got crabs. And you know what to do. SPEP, UPEP, skeletal survey. And this is going to confirm your suspicion because they have symptoms that this is indeed multiple myeloma. And with multiple myeloma, you get the bone marrow biopsy to confirm it, and it will show you greater than 10% plasma cells, which tells you, yes, indeed, it was multiple myeloma. And so you're either going to treat with chemo, transplant, or if they're very old, do nothing. Or they're going to present the patient who's asymptomatic or has an elevated protein gap. And because you see the elevated protein gap, you then get the SPEP, UPEP, and skeletal survey. And the SPEP will be positive, but the UPEP and skeletal survey will likely be negative. So now you're left with, I don't know, what is this? So you do the bone marrow biopsy. And then it is up to you to interpret the bone marrow biopsy results. And for you, it's going to be one of three things. If there are greater than 10% plasma cells, it's multiple myeloma. If there's greater than 10% lymphoplasmacytic lymphoma or lymphocytes, you've got Waldenstrom's. If it's less than 10%, you've got MGUS. Understanding that there is more than just these three diseases, but these are the three you have to know. MGUS, you just watch and wait. Waldenstrom, you treat with a rituximab-based chemo. And multiple myeloma is going to use a melphalan-based chemo. That's plasma cell dyscrasias.